looking at that renin-angiotensin aldosterone, okay, and causing fluid retention, right-sided heart failure. So we're checking that. Those are the tests we're doing. Okay, we're also doing liver function to show if there's hepatic congestion, increased liver enzymes, PT, INR, hyponatremia, and increased VUA and creatinine with decreased renal perfusion. Okay, because remember we said the kidneys get 25% volume of function. Okay. Now, pharmacological management, diuretics, ACE inhibitors, iotropes, phosphodiesterase inhibitors, okay, beta blockers, angiotensin II receptors, vasodilators, just to name a few. That's the pharmacological management, okay? And yes, we're watching that sodium closely. And if they start having fluid retention, we're restricting fluids, okay? And we're going to tell the patient to avoid excess fluids, okay? No alcohol, okay, because alcohol decreases myocardial contractility. So that's why I've been talking about alcoholism being one of the causes, etc. Alcohol decreases myocardial contractility, okay? So educate your patient on signs of worsening conditions. If they gain 3 pounds weekly or 1 to 2 pounds overnight, they need to notify their doctor. If they gain 3 pounds weekly or 1 to 2 pounds overnight, they need to notify their doctor. Okay? If they get orthopnic, they need to notify their doctor. Now, regular exercise is key and strongly encouraged. And think about it, the heart is a muscle. So regular exercise is going to increase the strength of that muscle. Okay? Let's answer this question. You have a question about that? I mean, if you exercise, think about how you feel when you at that last push, you're like, okay, I'm ready to go, but that heart muscle stops burning, you get short of breath, but when you go and you feel that burst and you can finish it, it feels good, okay? And usually, if you notice, people that are in good athletic shape and work out a lot or run, usually their heart rate is lower. Okay? They have a managed blood pressure, their heart rate is usually lower. Okay? The answer is 3, 5, 2, 1. Thank you. 3, 5, 2, 1. Let's answer this question. Which dystonia would you expect defibrillation to occur? Okay, the correct answer is 3 and 4. These are life-threatening rhythms. Okay. They require defibrillation. Now, the standard EKG is 12 leads, and it provides the best overall evaluation. Telemetry, usually there are 3 leads, and they're only going to show one view of the heart. That's telemetry. Okay. The Holter monitor is usually worn for 24 continuous hours, and then the doctor can see what the patient's heart has been doing for 24 hours. That's the Holter monitor. Okay. Now, clients may be asymptomatic until cardiac output is altered. So when cardiac output starts getting altered, they're going to start having symptoms. Okay? Like we talked about, urinary changes due to kidney function, okay, etc. They can complain of palpitations, syncope, changes in the pulse rate and rhythm can be seen in the EKG. So again, we always choose compliance, not the monitoring. This slide just shows the EKG rhythm, okay? What's happening. The P wave is atrial depolarization. Then you have your QRS complex, and that's ventricular depolarization. That ST segment is early ventricular repolarization, okay? T wave is ventricular repolarization, and then the PR interval is the time it takes for that impulse to travel through the SA node, okay? And then you have your R to R, which measures the regularity of the heartbeat, the R to R interval. Atrial fib, I kind of talked about that already. Patients have a high risk for CVA because of the possibility of clotting with atrial fibrillation. Okay? Anticoagulant therapy is necessary with AFib. Atrial flutter is a regular/irregular R to R interval. Okay? Patients can feel the fluttering in their chest. And it's a ventricular rhythm. So cardioversion may be used for either, but the doctor's going to do it in a cath lab under a controlled environment, and the patient will have anesthesia. Usually they'll be put under, okay, to get them to see if they can shock it back into a regular rhythm, okay? Now, you're focusing on rate control if the onset is has been greater than 48 hours, then a transesophageal echo might be required, okay? Let me go back because I just want to add a little information. When atrial fibrillation, like I said, yes, defibrillation may be required, but there's also medications, and we call it chemical cardioversion, okay? Amiodarone is one of those medications, okay? Its brand name is called Cobra, what it does, okay? But the generic name is amiodarone, okay? And that's a chemical cardioversion. Now, VTAC, there's wide, bizarre QRS complex. That's how you know what VTAC is, okay? It's long, wide, and bizarre. You want to prepare for synchronized cardioversion, okay? You want to check and see is cardiac output impaired and your cardiac rate. And administer antiarrhythmic drugs. VFib is a cardiac emergency. You usually know cardiac output. You want to start CPR and defibrillate as quickly as possible and administer antiarrhythmic drugs. These are just a few of the drugs. I'll just let you take a quick look at them. You want to know what they are. I see that you all have. I've noticed those pictures back because you got those nice drugs back there already. Okay. So if y'all have been studying these, this is amazing. So you'll know what they are. Okay. And what class they fall into. Let's answer this question. Okay. Yes, 1, 2, and 3. Okay, 1, 2, and 3. Inflammatory heart disease. Okay. So here I am again. When in doubt, take it out. Think about anatomical location of it. Think about where it is in your body. What's the purpose? You have endocarditis and pericarditis. You have a pericardial sac that sits around your heart. Okay. If you have endocarditis, it's inside of that sac right near the heart. Okay. Endocarditis. Itis, of course, is inflammation. So think about it. Signs and symptoms: fever, positive blood culture, say they have a murmur, hemorrhages, they might often be an IV drug user. Okay, could be related to that. Now, having said that, you'll give IV antibiotics for 4 to 6 weeks. You're assessing for right or left-sided heart failure, because remember, endo is inside, right there in the heart, next to the heart doing stuff, okay? If there should turn out to be valvular damage from this, patients may need a valve replacement, okay? Now, if they have had endocarditis, you want to teach your patients they will always need a prophylactic antibiotic before they have any type of procedure, okay? Even dental or pregnancy for the baby, okay? Pericarditis, however, is something that's going to occur on the outside of that pericardial sac, which is closer to what your chest cavity and chest wall. So you're going to feel what? Patient can feel a pericardial friction rub, and it's going to be painful, okay? So they're going to complain of that pain. You want to administer pain medications, okay? You want to teach them what orthoptic position, because that can help a little bit with relieving some of that pain, okay? So signs and symptoms. It's painful. It hurts more with a deep breath or when they're laying supine, okay? And then they feel that pericardial friction rub. So you're monitoring for ST segment elevation. You're monitoring the patient's hemodynamic status, and you're going to facilitate that orthoptic position. And we give NSAIDs for pain control. Now, there's different types of valvular heart disease. We have stenosis. The valve is fully open. That's what stenosis means. The valve is fully open. Insufficiency or regurgitation, that means the valve is fully closed. Insufficiency or regurgitation. The valve is fully closed. So, causes can be from rheumatic fever, congenital heart disease, syphilis, okay, endocarditis, as well as hypertension. Now, in the early period when a patient has mitral valve disease, early, when it begins, they may not have any symptoms, okay? But later, when that regurgitation gets worse, they're going to have excessive fatigue, orthopnea, dry coughs. So again, it can progress into hemoptysis, where they're coughing up frothy, bloody sputum, okay? Or pulmonary edema. And then they can have that rumbling, diastolic murmur, and a fever can also occur. So, we want to monitor our patient. We're monitoring their heart rate, their heart rhythm. We're doing our full assessments. We're looking at lab values, because we want to make sure that the organs aren't getting compromised. We're going to give that prophylactic antibiotic anytime they have a procedure, dental, pregnancy, toddler, okay? And they might need to get those valves replaced. So, if they get the valve replaced, they may not have a lifelong need for anticoagulant therapy, okay? If they get the valve replaced. Let's answer this question. It's a positive question, something the nurse should do. They can have cardiac tamponade, angina, chest pain. It can lead to heart failure, okay? Because that pain is very painful, okay? Very painful. This patient just needs transport, stable endo, where they get ready to go home. And of course, a fracture rib with pain of 6 out of 10, that just requires pain medication. When we look at vascular disorders, we are looking at arterial and venous. Know the difference between the two, okay? With arterial vascular disorders, there's power on elevation, weak peripheral pulses, okay? They're cool to touch, and they have painful non-adventitious ulcers, and you can hear the breathing. With the venous ulcers, they're warm to touch. Know the difference between the two. They have slightly painful ulcers with marked edema. Okay. Know the difference between the two. Capillary refill is less than 3 seconds, and they can have pruritus. So, these are some of the causes, but you want to encourage, you're the nurse, you're educating, you want to encourage smoking cessation if they smoke, regular exercise, encourage them to maintain an ideal body weight, follow the DASH diet, tight glycemic control is key, okay? And then tight blood pressure control, taking the ACE or the R medication, and treating hyperlipidemia or hypertriglyceridemia. So, atrial, we say bed rest, kick the extremity below the level of the heart. Venous, we say wound care, okay? Compression stockings day and evening, okay? And venous, they can elevate their legs at least 20 minutes, 4 to 5 times a day, okay? Arterial vascular disorders, they're gonna be on some antiplatelet agents, blood thinners, and they may need surgical graft, okay? They might need a surgical graft placed in order to get circulation to that extremity. Now, if you have abdominal aortic aneurysm, if your patient presents with this is the reason we do not palpate the abdomen before we auscultate. Because if you auscultate and you hear a bruit over the abdomen, do not palpate. It could be an abdominal aortic aneurysm. Okay? Now, it's a pulsating abdominal mass. The bruit can be heard over the abdomen. There's hypotension, jugular vein distension, and a widening pulse pressure. It can be confirmed on an X-ray. If it ruptures, yes, the patient will go into hypovolemic shock. Okay? Because think of, when in doubt, take it out. Think about where it is. Abdominal, that aortic aneurysm. If it blows, guess what? All that blood is going to pool here in the abdomen. And they can bleed out quick. Hypovolemic shock. Okay? So post-op care, signs and symptoms, renal failure. Why? Because if the patient bled out, the kidneys won't have the perfusion that they need. Okay? So you're assessing for renal failure, assessing for heart attack, ARDS, or post-op ileus. All that's happening in the abdominal cavity or the intestines. Okay? Changes in pulses, signs and symptoms of an occluded graft, because they're going to place a graft there to correct it. Okay? You don't want it to get occluded. There could be changes in the pulse, pain, and cyanosis to the extremities if it gets occluded because there's no circulation. Okay. DTE or DVT or clots, we've discussed those. Symptoms, calf pain, induration or hardening along the blood vessel, warmth and redness. You want to restrict ambulation, elevate the extremity, and they will wear anti-embolic stockings. And not the SCDs, because they have clots. Don't massage an extremity that has clots, okay? Now, medications, heparin therapy, we're checking the PTT. The antidote for heparin overdose is protamine sulfate, okay? The antidote for heparin is protamine sulfate. So, again, we're monitoring for Coumadin therapy, PT, and INR, and the antidote is maintained. They'll also be on they can be on antiplatelet agents and also clopidogrel. Let's answer this question.
said over 70, right?
70. You call the doctor with 70. This question, we have a 51-year-old client experiencing chest pain is brought to the ED by paramedics. The PCN begins collecting history data from the client. Client states pain started after a quick lunch from a taco truck. Client reports having chest pain after eating, which is relieved by chugging antacids. Though this time, the pain was not relieved. Selected physician orders the PN would anticipate from each of the following categories. Each category must have at least one option selected. Okay? So laboratory tests. Which tests are we going to select? Okay? I hear everybody saying all of them. Yes. Basically, because we don't know what's going on with him. So we're going to get a CBC, a BNP. Going to get those cardiac enzymes. See if he's had a heart attack. Okay? Now, diagnostic tests, what would we order? 12 EKG and chest X-ray. We want to see what's going on. Medications. Okay. We're going to give him some nitroglycerin and we're going to give him some magnesium hydroxide. Okay. Simply because what does he have? He says it's indigestion. Huh?
Could be an antacid overdose.
Well, the antacids might not be working, so, and yes, but we're gonna give some magnesium hydroxide, because that might work better than those antacids. Sure. Okay? All right. We're gonna start on, we'll go into chapter 6, we'll do about 20 minutes of it, so we can get some long chapter. We can at least get into that, for tomorrow. Indigestion, digestion, absorption, and elimination. Okay? So, when we start thinking about the GI tract, where does it start?
About
The mouth. Okay? And it ends right. Okay?
Yeah, but
so what goes in
must come out.
Okay. So, gastroesophageal reflux disease. Some patients are highly sensitive to different types of food, etc. We call it GERD. GERD is a symptomatic condition. It's secondary to reflux. Okay? The patient, the refluxes, that gastric contents can come up into the lower esophagus. It burns, okay? And it can cause severe problems in adult patients, okay? There's no one cause. It could be hiatal hernia, incompetent lower esophageal sphincter, decreased esophageal clearance, or decreased gastric emptying. So you're going to get a good history. In physical, you're going to ask for what causes those heartburn symptoms after you eat, so the patient will know their triggers. When that fluid comes back up, we call that eructation, okay? And it can burn. They usually have a fullness and a discomfort after eating. We diagnose it with esophageal, the LES or esophageal motility studies, okay? We also can diagnose it with what? Barium enema or barium swallow, hiatal hernia, or endoscopy, okay? Now, smoking cessation is what we encourage. Weight management, small frequent meals, and we want them to sit up at least 1 hour after they eat and stop eating 3 hours before bedtime, okay? Elevate the head of the bed 4 to 6 inches. They can put it on bricks, etc. That helps. Okay? Now, medications they can take, we know about the antacids. H2 receptor antagonists, they decrease those acid secretions. Proton pump inhibitors, okay? Mucosal healing agents and pro-motility agents. Now, peptic ulcer disease, okay? It's ulcerative ulcerations of the mucous membrane or other layers of the GI tract. Okay? It usually occurs in the stomach and duodenum, usually happens. Patients are usually aged 55 to 65. Okay? So common causes of peptic ulcer disease, H. pylori, that's an infection that can occur. Okay? NSAID use, excessive NSAID use, tobacco use, and alcohol and stress. Okay? Now, when we look at symptoms, the left epigastric pain, it can radiate to the back. You want to know these symptoms because these are hallmark symptoms for peptic ulcer disease. Okay? Nausea, weight loss, that irritation and distension, that left epigastric pain. Symptoms can occur 1 to 2 hours after meals and intensify with perforation or obstruction. Okay? Those would be medical emergencies. So, it's diagnosed, EGD, barium swallow, and testing for H. pylori. We're going to treat it if it's H. pylori with antibiotics. Okay? If it's perforation, hemorrhage, or penetration, or gastric outlet obstruction, surgery will be needed. Okay? Now, we're going to check the stools for occult blood because if there's some ulcerations, you might see some blood in the stool. Okay? You're monitoring the stool for color and consistency, and again, medication management to control symptoms and reduce acid, so we will give antacids. Complications can be the dumping syndrome. Okay? So we're going to tell our patients eat 6 small meals, high protein and fat and low in carbs, eat slowly, but avoid fluids during meals because we don't want that dumping syndrome. Okay? Anticholinergics decrease stomach motility, and we're going to teach them about lifestyle management, monitor for hematemesis and melanoma. Okay? Let's answer this question. Correct answers 1, 2, and 4. Okay? 1, 2, and 4. Let's answer this question. Okay. That's correct. Using NSAID. Okay. Now, when we look at celiac disease, it's an autoimmune disease. It's characterized by damage to the small intestinal mucosa from ingesting wheat, barley, and rice. So these patients will benefit from a gluten-free diet. Okay? Celiac disease. Symptoms, steatorrhea. That's a certain type of, what is that stool going to look like? It's floating, fatty. Okay? Floating, fatty type of stool. And it's kind of tan color. Okay? Now, abdominal distension and malnutrition can also occur. Other complications, decreased bone density, dental enamel, hypoplasia, iron and folate deficiencies, peripheral neuropathy, okay, and vesicular skin lesions. Now, laboratory testing, we're going to do a biopsy on that small intestine, okay? Early diagnosis and treatment are important to prevent the complications that come along with celiac disease. but yes, they've been adjusting that gluten-free diet. Now with Crohn's disease, I want you to know a few things, okay? Let me tell you, it's a chronic disorder characterized by inflammation of segments of the GI tract. Onset can be early adolescence or in the sixth decade of life. Okay? So, inflammation can be continuous or intermittent, and it extends throughout all layers of the intestine, and they can have a cobblestone appearance. Okay, that's Crohn's. Surgical interventions may be needed. They have right lower quadrant abdominal pain with Crohn's. Okay? Now, other signs: weight loss, fever, steatorrhea, 3 to 4 stools per day, and unexplained anemia. Diagnosed with barium enema with small bowel polyp. Now, the goal is to achieve remission, okay, from Crohn's. That's the goal. Monitor weight, encourage 2 to 3 liters of fluid a day. Low residue, high protein, high calorie diet, and limit fear. Okay? Provide emotional support for the client. We're going to give anti-inflammatories, multivitamins, and B12 injections. Make the client NPO during severe inflammation. Okay? And TPN is used for bowel rest. Now, we talked about Crohn's. Ulcerative colitis. These patients have 10 to 20 liquid stools a day. Okay? So we're thinking about the GI tract, we're thinking about all that fluid they're losing. So what are we looking at? Electrolyte imbalance. Okay? It's confined to the mucosa and submucosa of the colon. The cause is unknown. It could be autoimmune or genetic. Okay? Now complications from all those stools, bleeding, rupture, abdominal bloating, and they can have a toxic megacolon. Okay? Surgery, they might need a colon resection that might turn into an ileostomy, okay, a proctolectomy, and they may get a cock pouch, okay? Now, who knows what a cock pouch is?
What pouch?
Cock pouch. They take the intestine, the portion that's left, because they have to take a lot of intestine, and they re-anastomose it, and they can use the bladder, okay? And they make like a little pouch. And so it's gonna be in their bile as well as urine in that pouch that they build. Okay? And they may have like a little tube stoma coming out of there, okay? It's gonna be liquid effluent, okay? That's the cock pouch, because all of the segments is confined to the mucosa and submucosa of the colon. And if they have to have that colon resection and get an ileostomy, not a colostomy, I'm sorry, an ileostomy, that's combined with what? That's liquid, okay? That pouch is what they build, if they have to take all of that intestine, or these portion of the bladder, they just build it a little pouch that's gonna hold it, and then there'll be a stoma, okay, to empty the effluent. Okay? And that's just what a cock pouch is. So that's what ulcerative colitis. Because you gotta think about it, they got a 10 to 20 stools a day, okay? And then that lining is gonna deteriorate and wear down. Then if they start bleeding or
That's like every 20 or 30 minutes.
get that out of here, huh?
It's like every 20 or 30 minutes.
Yeah, it is. So, down here, it said electrolyte imbalance, yes. They're gonna be losing those fluids and electrolytes. Okay? Now with diverticulitis, I want you to take a look at this. This is the, we'll talk about this one in intestinal obstruction. That'll be our last one. Diverticulitis. If you look at these little pouches, these are called diverticulum, okay? Diverticulosis is the presence of those pouches, okay? Diverticulitis is when those pouches become infected and things get caught in them, like little seeds from strawberries, little sunflower seeds, nuts, and a patient can have a flare-up of diverticulitis, okay? Risk factors: age greater than 40, lack of exercise, obesity, smoking. Symptoms: left lower quadrant pain, fever, elevated WBC, ESR. Signs and symptoms of intestinal obstruction can occur. Okay? So we diagnose it with ultrasound, CT scan, and a colonoscopy. When we're looking at diet, you want sufficient fiber in the diet, okay? But avoid foods that contain seeds. If inflammation is present, that patient is gonna be put on the NPO, and they're gonna be progressed to a low residue bland diet, and they'll have bulk forming laxatives. They should avoid heavy lifting, tight clothing, and strain. Now, with intestinal obstruction, you can have mechanical causes. I want you to know the difference between these three causes. Mechanical causes for intestinal obstruction: adhesions, which is most common, strangulated hernia, and tumors. Mechanical causes. Neurogenic causes are paralytic ileus and spinal cord lesion. And the vascular cause is mesenteric artery occlusion. Symptoms: think about what it's saying: strangulated hernia, tumors, adhesions. There's sudden abdominal pain, okay? They may have had a history of obstruction. There are high-pitched valve sounds early in mechanical because some air can still kind of move through, okay? Then the valve sounds become diminished and absent. As the nurse, NPO, IV fluids, we're gonna do that nasogastric tube to decompress the gut.